God is spirit, and his worshippers must worship in spirit and in truth. John 4:24. Okay, so what we have here today is um, the question is asking about drug-induced thyroiditis and um, what exactly do you see? So here's the question. 40-year-old female is taking lithium for bipolar disorder and complains of increased thirst and heat intolerance. What are the arrows up down for TSH, T3, T4, radioiodine uptake, and then tonicity of the medullary collecting duct compared to the serum and serum ADH levels? Now, this is a multi-step question, but it is actually doable. So much better than TBG crap. Let me tell you. Actually, I can reason through this. Let me tell you what this is actually. So, if somebody's taking lithium, what kind of DI did they get? There's only two types of DI. So one is nephrogenic, the other one's central DI. Lithium is associated with nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus is when the kidneys um, don't work. There's uh, there's enough ADH in the body, but the kidneys can't use that ADH to retain water in the body. So when you have nephrogenic diabetes insipidus, you pee out all your water because your ADH is not working in the kidneys. So this patient has nephrogenic diabetes insipidus due to her lithium use, and now we have to see what is happening with the arrows. The arrows we have here is a TSH, T3, T4. Okay, so this lady has drug-induced thyroiditis. So her lithium is causing her to have nephrogenic diabetes insipidus and thyroiditis. So this is drug-induced thyroiditis. So she has heat intolerance and increased thirst. So heat intolerance, increased thirst. So this is hyperthyroidism. So you're gonna have increased T3 and T4, low TSH. Let me write this down. So I'm gonna write this down. Okay. Yeah, you're gonna have increased T3 and T4 and low TSH, and the radioiodine uptake is going to be low, right? In drug-induced thyroiditis, radio uptake is low. And now tonicity of the medullary collecting duct compared to serum. So remember how we said this lady has nephrogenic diabetes insipidus, so her ADH is up in the body. However, it's not working, so you pee out all your water. If you pee out all your water, you're gonna have increased osmolarity in your blood. But compared to the collecting duct, um, compared to the collecting duct, the osmolarity in the blood will be higher. So the osmolarity in the collecting duct will be lower because there's still more water in the collecting duct compared to the rest of the body. So it's going to be the arrow for the tonicity of the medullary collecting duct will be lower, and serum ADH levels is going to be high because the ADH levels are high in nephrogenic diabetes insipidus. Always. Yeah. See this. So patient has drug-induced thyroiditis and nephrogenic diabetes insipidus secondary to lithium. Similar to decorvan and postpartum thyroiditis, the patient can either be hyper or hypothyroid. Because this thyroiditis, uptake is low, even if the patient is hyper. In nephrogenic diabetes insipidus, sensitivity to ADH at the kidney is reduced. Sensitivity to ADH at the kidney is reduced, leading to decreased aquaporin insertion at the medullary collecting duct, and urine that is dilute, hypotonic compared to serum. ADH is high, not low, because the hypothalamus and posterior pituitary function just fine. The hypothalamus will increase production of ADH to compensate for the lack of receptor sensitivity at the kidney. Central DI, ADH is low. Okay, next. See, I like stuff like this. That makes sense. It's not a TBG binding stupid shit. Okay. Um, take a video. Like I would take I take pictures of these things so I can just go back and review it. Now we're going to do this question here. Um, it, this is all free stuff on the internet. So this is from Melman Medical, so you all can look into this. This is how I study. So, a 38-year-old IV drug user presents with 2-week history of progressive dysphagia, autonophagia, and fever. Autonophagia is painful swallowing. Okay. And dysphagia is difficulty swallowing. So dysphagia is difficulty swallowing, and autophagia is painful swallowing. And this guy has fever. Most likely cause of this patient's condition is most appropriately treated with an agent that does what? The answer is inhibition of 14 alpha demethylase. Yeah, okay. So you have to know that IV drug use equals increased risk of AIDS on the exam. The most common cause of infectious esophagitis in HIV and AIDS is Candida. The treatment for Candida esophagitis is oral fluconazole, 200 to 400 mg per day for 14 to 21 days. You don't need to know the doses for USMLE. That he just wrote that there because he's pretty cool like that. But the treatment for Candida esophagitis is oral fluconazole. Okay, azoles are antifungals that inhibit ergosterol synthesis by inhibiting 14-alpha demethylase. Ergosterol is the cholesterol equivalent in fungi. Terbinafine inhibits lanosterol synthesis by inhibiting squalene epoxidase. Lanosterol is a precursor to ergosterol. Lanosterol is the precursor to ergosterol. Topical terbinafine is a first-line treatment for tinea pedis. Oral terbinafine is the first-line treatment for onychomycosis, fungal nail infection. So the rest is for other stuff. Amphotericin B is for very, very sick patients. Um, swallowing is not a very, very bad problem. Like, issues swallowing, so. So you have to know the mechanism of action of the fungals to score above the 220s. Okay, so take home point here is what? Patient has candida. You have to know the HIV patient usually has candida. If they have a candidiasis, candidal esophagitis, you treat with oral fluconazole, and the mechanism of oral fluconazole is to inhibit ergosterol synthesis by inhibiting 14-alpha demethylase. This right here. I'm going to take a picture of this. Next. Uh, 56-year-old woman comes to a doctor for an annual health maintenance exam. BMI is 25. A complete CBC shows no abnormalities. Her serum lipids are as follows. Total cholesterol is 195, HDL is 55, triglycerides is 520. She's 56 years old, BMI is 25. Triglycerides are through the roof. In addition to a lifestyle modification, Which of the following agents is most appropriate? Triglycerides. Okay. Atorvastatin. No. Fenofibrate, maybe. Niacin. I don't think so. Between fenofibrate and azathimb. I don't remember. But there we go. Oh no, it's fenofibrate. Okay, fibrates such as fenofibrate and gemfibrozole are indicated in the primary treatment for triglycerides. Okay, very cool. Let's write this down. And fenofibrate is the most commonly implicated fibrate in causing liver injury, which can be severe and prolonged with autoimmune disorder. Okay, so fenofibrate causes liver injury. Gemfibrozole eclipses fenofibrate for causing myopathy when used in conjunction with statins. Yeah. So if you use statins and fibrates together, that causes myopathy. Gemfibrozole interferes with statin glucuronidation, whereas fenofibrate does not. Okay. The guidelines for initiating statin therapy are likely and vary depending on individual risk. USMLE will not be pedantic about exact figures, but Step 2 CK wants you to know the following. We don't need to do that right now because we're trying to pass Step 1 right now. So that's that. Niacin is for HDL. Azathimb is the selective cluster absorption inhibitor in the small bowel. It lowers LDL by 13 to 20%. Okay, it's for LDL, high LDL. Okay, next. They tell you farmers have worse subject. There is no. He doesn't have a farm module. I wish I could just go through it, but he doesn't have a farm like PDF. Okay. Which of the following best describes the mechanism of action for this therapy? 32-year-old woman has a 7-month history of gradually worsening pain and stiffness in hands. Wrist and ankles. She began taking 800 mg ibuprofen 7 months ago, which had resulted in temporary amelioration of her symptoms, but now is ineffective. Serum studies show positivity for RA and anti-cyclic citrullinated peptide. She started on a short course of prednisone that does not relieve her symptoms. The physician discusses his recommendation for commencing a disease-modifying anti-rheumatic drug, which I find best describes the mechanism of action for this therapy. DMARD. Okay. DMARD. It's not inhibition of CD80. It's not IL-6. Inhibition of TNF alpha receptor. Inhibition of dehydrogenase reductase. I don't know. I'm gonna go with this. Oh, it is okay. Methotrexate. Okay. So methotrexate is a competitive and a reversible inhibitor of dihydrofolate reductase (DHFR). Is the well-established first-line DMARD used to treat RA. As soon as diagnosis of RA is made, it is recommended that DMARD therapy is commenced. Okay, so as soon as somebody is diagnosed with rheumatoid arthritis, you give them DMARD therapy. NSAIDs such as ibuprofen and glucocorticoids may be used for symptomatic relief, but they don't halt progression of disease. Glucocorticosteroids are generally implemented as a short taper while the initial DMARD being commenced. While the initial DMARD is being commenced. Okay, so first you give ibuprofen and glucocorticoids for symptom relief, but then you have to give them DMARD. What is DMARD? Methotrexate. And if methotrexate does not work, you give leflunomide and sulfasalazine, which is a combination DMARD therapy, or give TN alpha agent therapy. Okay, so bottom line, methotrexate is a competitive reversible inhibitor of DHFR. It causes pulmonary fibrosis, hepatotoxicity, and mucositis due to neutropenia. Depending on the severity and progression of RA, anti-TNF alpha agents are frequently used as a step up after methotrexate. Okay, for RA, give DMARD. DMARD, which is methotrexate, which is methotrexate. What is the mechanism? Um, um, the mechanism is inhibition of dihydrofolate reductase. Okay, next. The inhibition of dihydrofolate reductase. I feel like they always ask this question, always. And somehow I always pick dehydrogenase or something else. But the answer is the inhibition of dihydrofolate reductase. Now, something else you gotta know is that methotrexate, it causes pulmonary fibrosis, hepatotoxicity, and mucositis. Um, if the RA is really bad, you have to give TNF alpha. You have to add it. Okay. Next. Hi. Which of the following chemo agents may demonstrate efficacy in the management of a patient? Okay. 14-year-old lady and 14-year-old girl is referred to doctor complaining of ongoing abdo pain and distension for the past 2 months. Okay. A physical exam shows a distended but non-tender abdomen with a painless, immobile, firm mass, inferior and lateral to the umbilicus on the left. Okay. Inferior and lateral to the umbilicus on the left. Bone marrow and hematologic exam are normal. Basic metabolic panel is within limits. Abdominal CT confirms a mass surrounding inferior mesenteric artery Burkitt lymphoma is diagnosed. CD positive, CD20 positive is reported by immunochemical exam. Which of the following chemo agents demonstrate? Okay, so CD20, all I remember is that rituximab affects CD20, so I'm gonna go with that. Okay. Patient has Burkitt lymphoma type of non-Hodgkin's lymphoma. Dangerous. Okay. Remember the Hodgkin's one has a good rate. Non-Hodgkin's is bad. Although jaw lesions have been classically described in the literature, intra-abdominal Burkitt lymphoma has been reported to account for more than 50% of cases. Jaw lesions appear to be associated with male gender at a young age. Rituximab is a monoclonal antibody that targets CD20 and B cells. It is used in treatment of non-Hodgkin's lymphoma. It may be used in the treatment of autoimmune disease such as RA and granulomatosis with polyangiitis, formerly known as Wagner's. This agent is extremely high yield for USMLE. Please give me the sixth question. I need it. You know what I hate? I hate graphs. Like anything that has to do with graphs, it drives me crazy. It takes me forever to understand. That's why I suck at biostats. Oh my gosh. But stuff like this, I feel like it just sticks. Daclizumab, what the heck is that? Is a monoclonal antibody against CD25, the alpha subunit of IL-2 receptor on T cells. Okay. Is a monoclonal antibody against CD25. Okay. Would you believe me if I told you I never heard of Vemura Venfinib? Oh my gosh. I would think that's something they made up on the exam. Cefuximab is a monoclonal antibody against epidermal growth factor (EGFR), the treatment of EGFR positive metastatic colorectal cancer. Okay. Oh, interesting. Okay, bottom line. Rituximab is a monoclonal antibody against CD20 and B cells. The agent is high yield for a step. The other agents are listed as per game on step and are not random obscurities. Okay, but to pass USMLE, you need to know rituximab. Okay, so I guess we need to know the rest too. So daclizumab is a monoclonal antibody against CD25, IL-2, the alpha subunit of IL-2 receptor on T cells. Vemurafenib is an inhibitor of BRAF, serine, theanine kinase in the treatment of BRAF mutated late-stage melanoma. Okay. Remember Khloe Kardashian? Not Khloe, is it her? Khloe, yeah, it is Khloe Kardashian. Who's that blonde one? Oh my gosh. I forgot stuff that happened in the outside world. When I was studying for STEP. There's Kim Kardashian, there's Courtney, and there's Khloe. Yeah, Khloe is the blonde. She had melanoma actually. Vemurafenib is an inhibitor of BRAF, serine, theorin kinase. The treatment of BRAF. Okay, mutated late-stage melanoma. Okay. Vemura. Okay. Cetuximab is a monoclonal antibody against EGFR in treatment of colon cancer. Epidermal growth factor receptor. Alemtuzumab is against the antibody against CD52 in the treatment of CLL. Oh my goodness. Eculizumab is a monoclonal antibody against complement protein 5 in the treatment of PNH. Bottom line, rituximab is a monoclonal antibody against CD20 on the B cells. Agent is high yield for a step. Okay, so we're just gonna go with that. Rituximab. Rituximab is monoclonal antibody against CD20 on B cells. No. Okay. Okay. Um, he then carries out kinetic studies of purified enzyme and presents his findings in a report. L-asparaginase is an integral component of treatment of ALL in kids. Okay. It hydrolyzes L-asparagine to L-aspartate on leukemic cells. A researcher who is investigating this enzyme isolates an actinomyces strain, Streptomyces species something 82, which produces L-asparaginase. He then carries out kinetic studies of purified enzyme presents his findings. What? Okay. Which of the following most accurately describes the researcher's findings of L-asparagase in comparison to his prior estimations? L-asparagase is a major part of ALL treatment in kids. It hydrolyzes L-asparaginase to L-aspartate in leukemic cells. As a researcher who was investigating this enzyme, this enzyme isolates an actinomyces strain, a streptomyces strain, which produces L-asparaginase. He then carries out kinetic studies of purified enzyme and presents his findings. Okay, researchers report KM. Findings as per kinetic studies. Vmax. Okay. Which of the following most accurately describes research findings of L-asparaginase in comparison to prior estimations? Okay. I don't even know how to approach this. Um, they're asking, well, should I describe researchers' findings? Okay, researchers' findings of L-asparaginase in comparison to prior estimations. Okay, so which of the following most likely describe research findings? Findings per kinetic studies. 0.01. Okay, Vmax. Um, I'm just gonna have to guess. I have no idea. Okay, D. Um, so bottom line, Km is equal to substrate concentration at half Vmax. Km is equal to substrate concentration at half Vmax. Increase Km means decrease affinity. Decrease Km means increase affinity. Increase Vmax. Oh my gosh. The true finding. Okay, I got it. Okay. So, but what they're saying is, um, if Km is down, then then affinity will increase. So then less substrate is needed to bind the enzyme. And then if Vmax is up, then efficacy will increase. So enzyme can achieve a higher maximum reaction time. So look at this. Km, right? Uh, this is the researchers' prior experiments, and this is the researchers' new findings. So Km, look at Km, just two columns. So Km and then there's Vmax. Km, it was 0.02 and then dropped to 0.01. So it decreased. Km decreased. And if Km decreases, that means affinity will increase. You had to just memorize that. If Km decreases, then affinity will increase. And if affinity increases, that means there is less substrate needed to bind the enzyme. There is less substrate that's needed to bind the enzyme. You have to memorize that. Okay. Next, the second column is Vmax. Vmax, if it increases, even if it's slightly, then efficacy increases. That's it. So it went from 95 to 95.08. So efficacy went up. So the two things, memorize this line. If Km is down, then affinity will increase. So less substrate is needed to bind the enzyme. If Vmax is up, then efficacy will go up. So enzyme can achieve a higher maximum reaction time. So simply, Km is up, then affinity is up. If Vmax is up, then efficacy is up. Efficacy is up. Now, reverse. If Km is down, that means affinity is down. Vmax, yeah. V. And then if Vmax is down, that means efficacy is down. Well, that last part was wrong. Don't listen to the last part. The last part is I said if Km, whatever I said, don't listen to that. Just the last part. The correct version is if Km is down, affinity is up. If Emax is up, then efficacy is up. Okay, so if Km is down, affinity goes up. If Vmax is up, efficacy goes up. Now, that's the only thing I have to memorize. So just write like if Km is down, then that means affinity goes up, and if Vmax is up, that means efficacy goes up. And then if you can use this for any Vmax and Km questions, because here we know that if Km is down, then affinity goes up, and if Vmax is increased, then efficacy goes up. So in reverse, if they ask you if Km is up, you just flip the arrows. Affinity goes down. And if Vmax is down, then efficacy goes down. So just memorize one, and then depending what they ask you, if Km is up or down, switch the arrows to that. So what is it? Km If Km is down, then that means affinity goes up. Yes. And if Vmax is up, that means efficacy goes up. That's it. That's all they're asking. Even though I hate questions like this, I don't know how this will help any doctor. And no patient is gonna come with KM and Vmax issues. I am letting my intrusive thoughts talk, but I don't care. Next. Okay, this is actually useful. Let's go. Serum cryptococcal antigen of 1 is to 64 is reported, which the following should be initiated in this patient. 63-year-old the man with the medical history of type 2 DM, COPD, Hep C, Hep remote, IV drug use presents to ED with debilitating headaches, progressive gait instability, weakness when standing, and 15 kg weight loss over the last 2 months. He works at a plastics factory and spends his lunch breaks at a local park where there's a huge pigeon population. Serum cryptococcal antigen is 1 to 64 is reported, which the following should be initiated in the patient. Hey, okay. Um. Well, he has a rapid weight loss. That means he has AIDS, right? Like his AIDS is pretty severe. For severe infections, you give amphotericin B. I think it's flucocytosine. Let's see. So amphotericin B and flucocytosine. Yes. Yes. Happiness overload. Okay. Hold on. So you need to know the fluconazole. So for cryptococcal meningitis, the treatment is amphotericin B and flucocytosine, followed by a fluconazole taper. Okay, flucocytosine. That's it. Next. Okay. Which of the following is most appropriate first line treatment for patient? Okay, so this patient, a 54-year-old dude comes to ED 90 minutes after attending a party for his friend's cellar. In his friend's cellar, he complains of severe stomach cramping, worsening visual disturbance. He appears acutely intoxicated. Certain studies show bicarbonate very low. Okay, sodium in normal, chloride 100, pH 7.14, so guys, pH low, bicarb low, um, CO2 low, O2 fine. Which I find most appropriate treatment. Okay. Um, Famezipol. I think it's Famez. What is it? Fameprazole. First of all, what kind of thing does he have? This 90 minutes, right? Okay. He has some kind of acidosis. Um, Metabolic acidosis with respiratory compensation, I guess. Metabolic acidosis. Yeah. So, but what is it? What is the compensation? First line treatment for methanol and ethylene glycol intoxication. It is a potent alcohol dehydrogenase inhibitor. Ethanol is also an effective treatment but famezipol is the correct answer on USMLE. Okay, so intoxication is classically associated with consumption of home distilled alcohol. Individuals typically seek medical attention within 12 to 48 hours because of abdomen pain, encephalopathy, and dark blurred vision. High iron gap metabolic acidosis is characteristic. Okay. Yes, he has metabolic acidosis with the respiratory compensation. Toxicity is due to metabolism. Toxicity is due to metabolism to formaldehyde followed by formic acid. Okay, toxicity is due to metabolism to formaldehyde followed by formic acid, with the latter being more toxic. Yeah, formic acid is worse due to metabolism to formaldehyde, followed by formic acid, with the latter being more toxic. First-line treatment is fomezepal, a potent inhibitor of alcohol dehydrogenase. This is due to first-line treatment of ethylene. This is also the first-line treatment for ethylene glycol um, antifreeze poisoning. Okay. The use of ethanol is in the treatment of methanol and ethylene glycol. Poisoning is also considered effective, but uh, Fomezepal, whatever, Fomepizole is the first line treatment. Ethanol works by competitive saturation of alcohol dehydrogenase, thereby allowing the increased time for unmetabolized renal clearance of methylene and ethylene glycol. Phenaldipam is for hypertensive emergencies. Phenaldipam. Okay. Pralidoxime is used after atropine in the is used after atropine in the treatment of OP poisoning. Organophosphate poisoning functions to regenerate functional acetylcholinesterase. Okay, so if somebody is drooling. If let's say somebody is, they're not to work on the farm, they come in with drooling, and they're like almost unconscious. That is organophosphate poisoning. That Yeah, so you give pralidoxime. First you give atropine, then you give pralidoxime. Pralidoxime regenerates acetylcholinesterase. Acetylcholinesterase is the thing that breaks down acetylcholine. So the problem with OP poisoning is that there is too much acetylcholine in that person's body. You want to get rid of the acetylcholine, so you give pralidoxime, which will regenerate the acetylcholine. Uh, the thing that breaks down acetylcholine. Sorry, the thing that breaks down acetylcholine, so that the person can stop drooling. Okay, now this is from Mesopol. Okay, so the only thing you need to know is that fomepizole is for methanol, and ethanol is given for methanol and ethylene glycol intoxication. Fomepizole inhibits alcohol dehydrogenase, so methanol doesn't convert into formic acid, and so that ethylene glycol doesn't convert into glycolic acid. That's it. Next. Okay. So a previously healthy 64-year-old lady arrives at ED after a 2-hour history of chest tightness and burning. BP is 162, 93. Heart rate is 92. There is jugular venous distension and crackles auscultated in lung fields bilaterally. ECG shows STL segment elevation leads to 3 and AVF, which I find most appropriate initial pharmacotherapy. Okay. Previously healthy 62-year-old male arrives at ED after 2-hour history of chest tightness and burning. BP is 162, heart rate is 92. There is jugular venous distension and cackles heard in the lung fields bilaterally. So he has right heart failure and crackles. Okay, that he has both then. Right and left heart failure. Um, and he's having a heart attack. Okay. Um, what do you give first? Um, um, what is prasugrel? No, I don't know what that is. Um, heparin is for a clot. I'm gonna go with aspirin and heparin. I don't know. Okay, prasugrel. That was correct. So, combination of aspirin and an ADP2Y12 blocker like clopidogrel, prasugrel, or tricaglor is what you give for acute coronary syndrome rather than giving aspirin alone. Rather than giving aspirin alone. Next, okay. Reduction in BP, log dose, drug X and Y, drug Y, drug X, and regarding the above findings, which of the following is true? Okay. Reduction in BP. So the most efficacious one is drug X, right? The low, you just need a little bit to produce the same effects as drug Y. So drug X 5 times drug Y. And for drug X plus 5 doses of drug Y. Okay, drug Y. Drug Y is a non-competitive antagonist of drug X. No. Drug X is a non-competitive antagonist of drug Y. No. Drug Y is a competitive. No. Drug X is a competitive. No. I don't think they're antagonists. I think they all work together. Drug Y is a partial agonist of drug. Drug X is a partial agonist of drug Y. Last two. Drug Y is a partial. Okay, that means something. Drug Y is a partial agonist. Maybe. Drug X is a partial agonist. Maybe it's this one. Look at me, you're trying to reason through things. What the heck? Alright, let's read this. So, guys, this was not easy for me, but this is the answer. Drug X is the agonist that lowers the blood pressure, the black line. Drug Y is a competitive antagonist that binds the same receptor as drug X. Competitive antagonists shift the curve to the right always. And when drug Y is present, you must give more drug X to displace drug Y and restore the effect, with the same maximum effect eventually reached, which is exactly why drug Y is a competitive antagonist of drug X. So what they're saying is black line is drug X and drug Y doesn't have a line by itself. all of these lines, all three lines are actually drug X, and but the purple line and the yellow line are is what uh, drug X would be when drug Y um, um, is acting along with drug X. So drug X by itself is is the black line, and then the purple line and the tan line is drug Y added to the drug X. And what we have to know from this is that drug X is the agonist that lowers the BP, and drug Y is the competitive antagonist that shifts the curve to the right. That's what all competitive antagonists do. They shift the curve to the right. So you need more. You need more of drug X to displace drug Y to get the same effect as you see in the black line. So that's what makes drug Y a competitive antagonist of drug X. So you need more drug X, which is the agonist, the black line, to displace drug Y, which is the competitive antagonist, and reach the same effect as drug X alone, which is the black line. The rightward shift with the same maximum effect, you see the height? That's the maximum effect of all three lines. The rightward shift with the same maximum effect is the hallmark of competitive antagonism. So we have to know just general knowledge, but even though it's not general knowledge because I just found out today, the black line is the agonist, and that yellow line and the purple line, those would be the two competitive antagonists because that those two lines shift the curve to the right. Okay, that's it. Oh my. I wish I could cross stuff out, but I can't. Okay, let's see. A 44-year-old man with advanced hemochromatosis has progressive confusion over the past 1 hour. Oh, past 4 days. Okay. Physical exam shows asterectosis. Lactulose is administered, which rapidly improves the mental status, which of the following best explains the effect. Okay, so lactulose. What does lactulose do? Lactulose. I think lactulose turns NH3 into NH4 ammonium to get rid of the to get the acid out of the body. NH3 to NH4. Okay, acidification maybe. I think it acidifies, and then it decreases the ammonium absorption. Um, I think it's in the bowel. Uh, okay, so acidification, ammonia absorption. I think it decreases the ammonium absorption in the bowel. All right. Let's see. Decrease. Maybe it's acidification and then a decrease in ammonia absorption in the bowel. Let's see. It's okay. We'll learn if it's not. Oh, dang it. Acidification, ammonia. Oh, damn, ammonia. Wow, no. Okay. Uh, ammonia absorption in the bowel. Okay. Okay. So, decrease in ammonia absorption in the bowel. So, I knew that. I don't know why I did this. Ammonia is NH3. Ammonium is NH4. Let's just check. Yeah. So it converts NH3 to NH4 so it can get excreted. So yeah. Let's see. Lactulose is a treatment for hepatic encephalopathy. Gut bacteria metabolizes it into acidic end products that result in the trapping of interlumina NH3 as NH4, which in turn gets excreted due to non-absorption. Right. I knew that. I don't know why. I don't know why. Okay. See, that's the thing. When you're in a hurry, you don't read properly. But that's okay. Now we know. So I know lactose, it converts NH3 to NH4 to get rid of the body. So NH3 itself is ammonia. So ammonia is a base, right? Ammonia is a base. The body needs to convert the base to an acid to get to excrete it from the body. So it converts the NH3 to NH4 because NH3 is a base and NH4 would be an acid. So yeah. Hemochromatosis causes cirrhosis and cause other issues like the huge heart and stuff, but it's okay. We're talking about liver now, and so the liver can't function properly, and so now you have asterixis. It's a neurologic sign of flapping hands with outstretched arms, seen classically in liver failure, but may be seen in renal and respiratory failure, as well as the use of some drugs. Um, Hepatic encephalopathy is confusion descending of liver failure due to the inability of the failure of the liver to process ammonia, leading to hyperammonemia and deleterious effects on CNS function. Confusion in setting liver failure, yeah. Because your liver, so your liver normally converts ammonia to urea and then eliminates the kidneys eliminate the urea in the urine. But since your liver um, cannot convert NH3 to urea, that NH3 builds up in the blood, and that's what causes asterixis. Yeah, and now doctors give lactulose. It is a disaccharide composing of galactose and fructose. It is a treatment for hepatic encephalopathy. It is metabolized by gut bacteria to monosaccharides and then volatile fatty acids, hydrogen and methane, with the net effect being a reduction in gut pH. This causes the increased conversion of interluminal ammonia into ammonium, which cannot be absorbed by the same way ammonia can. This leads to a decrease in ammonia levels in the body, thereby mitigating the hepatic encephalopathy. So lactulose is a treatment for hepatic encephalopathy. Gut bacteria metabolizes it into acidic end products that result in the trapping of interluminal NH3 as NH4, which then is excreted due to non-absorption. Okay, so this is how you look for step one. You have to know that lactulose causes acidification and decreases ammonium, which is NH4, absorption in the bowel. Liver normally converts NH3 to urea, and urea gets peed out. Um, but in cirrhosis, liver cannot convert NH3 to urea, so NH3 builds up and lactulose is given. So NH3, which is a base, can be converted to NH4, which is an acid, to get pooped out. That's it. Okay. So here we have a 64-year-old man with a history of AFib They managed with warfarin experiences right-sided arm weakness and facial droop for the past 12 hours. Recent farm treatment for which of the following conditions might explain this finding? Okay. He just had a stroke despite being on warfarin. Warfarin is a blood thinner, so warfarin makes the blood thin. It prevents clots from happening. Okay. Um, it prevents clots from happening. Despite that, he had a clot. I'm gonna go with VTech. Can't really. Oh, what the heck? I did not know that. Okay, so this patient developed stroke symptoms despite being on warfarin because he was treated with for a scalp fungal infection, tinea capitis, with griseofulvin, a cytochrome P450 inducer that increases the metabolism of warfarin, reducing warfarin's anticoagulant effect and allowing a clot to form, causing the stroke. So you have to know that chart for inducers and inhibitors. For inducers, you have to think of there's a mnemonic. Um, the one I know is crap GPS. So crap GPS. So C. I'm saying from memory. Crap. Let's see. C would be carbamazepine. Crap. R is for rifampin. A. I don't think there's an A. P would be phenytoin. Crap. G would be griseofulvin. GPS, and the other P would be for phenobarbital, GPS, and S would be St. John's wort. I'm just gonna check it. Crap, CRAP, GPS, CRA. Yeah, there's no A. Oh wait, alcohol use, chronic alcohol use. There is an A. Okay, CR. So C would be for carbamazepine, which is a mood stabilizer. R, which is R for rifampin, which is a tuberculosis drug. A, alcohol overuse. P, phenobarbital. Crap. G, griseofulvin, which is for tinea capitis. The other P, phenobarbital. I mean phenytoin. So we already did phenobarbital, phenytoin, and S is St. John's wort. Now for inhibitors, the mnemonic I know is sickfaces.com. I'm going to say this from memory. So S is. Okay, we'll come back to S. I is isoniazide. Sick. C would be. Cimetidine. K, sick faces. So K would be ketoconazole. F would be fluconazole. Sick faces. C, SICK. F is fluconazole. A is acute alcohol overuse. C is chloramphenicol. E is erythromycin and clarithromycin, which are the macrolides. The S is sulfonamides.com. The C will be ciprofloxacin. O will be omeprazole. M is metronidazole. And then there's amiodarone and ritonavir and grapefruit juice. But this is like a really tough question because it's like second and third order thinking, you know? It's not. This is not easy, but he says it's like exceeding the high yield for step one, so they can ask anything. Unfortunately. So I'm gonna say the inducers again, and I'm gonna say the inhibitors again. So inducers is crop GPS. C would be for carbamazepine. R is for rifampin. A is for alcohol overuse. P is for phenytoin. Crop GPS. G is for glycosylflavin. P is for uh, phenobarbital. S is for St. John's wort, and then those are the inducers. And now the inhibitors would be sickfaces.com. S would be for sodium valproate, sick, and then I would be for isoniazid. C for cimetidine. K is ketoconazole, sick faces. F is for fluconazole. A is acute alcohol overuse, sick faces. FAC. C would be for is it clarithromycin? Let me check. Nope, it is chloramphenicol. Chloramphenicol, not clarithromycin. Clarithromycin is not even on the list. It's chloramphenicol. Chloramphenicol is what causes gray baby syndrome, I believe. Yeah, chloramphenicol causes gray baby syndrome. Okay, think of like your baby's gray, it's inhibited. So that's the only way I can think of it. Because I keep saying clarithromycin, that's not even on the list. So think of gray baby syndrome for chloramphenicol, and that's an inhibitor. So sick faces, FACE would be erythromycin. Uh, yeah, erythromycin. Oh my gosh, clarithromycin is on the stupid list. I need to stop. I need to stop like double guessing myself. I'm such a weirdo. I'm not confident in my answers. Okay, okay, I need to stop. Okay, clarithromycin is on the list. So sick faces. FACES. Now, what does that S stand for? FACE. And what? I don't know what S is. Hold on. Sick faces. Because we did sodium valproate. Sulfonamides. Okay, sulfonamides. Okay. And then Cipro.com would be ciprofloxacin, and then omeprazole, then metronidazole, and then amiodarone, and ritonavir, and grapefruit juice. So sickfaces.com, ARG. Sickfaces.com, GRARG. So sickfaces.com, ARG. Okay. That's the thing. I feel like nobody asked about amiodarone or ritonavir. You know, I think they make it very obvious what they're asking about because there's no way in hell everyone like anyone can memorize this entire list and then apply it to a question to find out and do reverse psychology to find out which drug was given that induced or inhibited whatever to cause somebody's stroke. Because that's wild. Okay. So sickfaces.com ARG. I'm gonna go over that one more time. S is for sodium valproate. I is for isoniazid. C is for cimetidine. K is for ketoconazole. Sick faces. And then F is for fluconazole. A is for acute alcohol overuse. C, FAC. Uh, okay, chloramphenicol. E is for erythromycin and clarithromycin. FACE, and then S is sulfonamides.com. The other C is for sick faces, sick, FACE. Oh, is this cemetery? I already did cemetery. Sickfaces.com. Okay, we'll come back to that. C. O is omeprazole. M is metronidazole. Ciprofloxacin. It's ciprofloxacin. Okay. Ciprofloxacin. Okay. And then amiodarone, right? Ritonavir, grapefruit juice. Okay. Okay, next question. Which of the following is the most appropriate pharmacologic agent to improve symptoms? A 64-year-old man with a congestive heart failure has worsening dyspnea for the past few hours and peripheral edema up to knees. He has history of sulfa allergy. Which of the following is the most appropriate farm treatment to give? Okay, sulfa allergy. Wouldn't it be um, furosemide? Or I think I thought it was furosemide, but let's see. It's atropinic acid. Loop diuretics are first-line treatment for fluid unloading in a patient with symptomatic heart failure. Furosemide is standard go-to loop diuretic. It's a sulfa drug and can't be used in patients. Oh, okay. With sulfa allergy, atherogenic acid is a non-sulfa alternative to furosemide that may be used in the setting of heart failure. Oh. It's highly for step to know that loop diuretics such as furosemide and atherogenic acid notably cause reversible autotoxicity. Okay. Hydrochlorothiazide amiloride spironolactone may be used for fluid unload, used to fluid unload in heart failure. However, loop diuretics are more effective. Mannitol, an osmotic diuretic, is contraindicated in congestive heart failure because it increases circulatory volume, thereby increasing preload and oxygen demand on heart, in addition to exacerbating pulmonary edema. So, loop diuretics are first line of treatment for symptomatic heart failure requiring fluid unloading. Furosemide is a standard go-to agent. However, it is a sulfa drug and most be avoided in patients with sulfa allergy. Ethacrylic acid is a non-sulfa alternative to furosemide. Loop diuretics can cause autotoxicity. What? Okay. So the loops you give for heart failure who have fluid buildup. Furosemide is the standard go-to agent, correct? However, furosemide is a sulfa drug and has to be avoided in sulfa allergy patients, so you give ethacrylic acid. Okay. 29-year-old lady from Indonesia has PPD test as part of immigration health check for TB. Duration of 11 mm is observed. Chest X-ray is ordered and is unremarkable. Which of the following is the next best step in the management? Okay. Yeah. So she's positive for TB because I think it's only supposed to rise a little bit. Um, but if it rises a lot, that's like abnormal. So um, isn't this more like a step 2 CK question? I don't know. I'm gonna go with this. Let's see. Oh, it is. Okay, so INH and pyridoxine for 9 months. So this girl has measure in duration only. Arrhythmia does not count. So she had over 10. Immigrant status, Western countries not included, IV drug users, healthcare workers, prison workers, homeless shelter personnel, TB lab personnel, children under 4 years. Okay, so this patient has know the diagnostic algorithm and latent active treatments for TB. Always give vitamin B6 with INH. This is exceedingly high yield for a USMLE. Thank God they only decided for one option. Okay, so um, let's see. The man has latent TB, positive PBD test, a negative chest X-ray. The card cancer is discussed below. Must include B6 in regimen. PBD skin test is performed first diagnostically if history of BCG vaccine. So PBD test is performed first diagnostically if there's a history of BCG vaccine. Do interferon gamma release assay instead. Do not do interferon gamma release assay in addition to PBD. Okay. If PBD is negative, repeat after 1 week. If again negative, no further studies indicated. Repeat tests performed within 1 week may cause a false or positive secondary to a booster reaction. Right. So if the interferon gamma release assay test is negative, no further studies are indicated. If PBD or IGRA is positive, then do the chest X-ray. Do not repeat positive PBD test. Okay. If IGRA is negative, no further test needed. If PPD or IGRA is positive, do chest X-ray. Yeah, if PPD or IGRA is positive, do chest X-ray. Don't repeat positive PPD test. If chest X-ray is negative, treat for latent TB. Give TB prophylaxis. On step 1, treatment for latent TB and administer TB prophylaxis mean the same thing. If chest X-ray is positive, treat for active TB. So if it's 5 millimeters, that like more than 5 millimeters, that means that they had recent contact with the people with active TB, they or HIV positive status people, or organ transplant recipient, or chronic prednisone use over 15 mg per day, or anti-TNF alpha agent use, or findings consistent with TB on chest X-ray. Over 10 is immigrant status, like this lady. At 15, everyone. Treatment of latent TB, 9 months with isoniazid and pyridoxine, which is B6. Okay. 4 months of rifampin, or 3 months of isoniazid plus rifapentine and pyridoxine, or vitamin B6 must be given with INH to prevent B6 deficiency. Treatment of active TB, rifampin, INH, pyrazinamide, ethambutol. Okay, this is a RIPE treatment. That's for active TB. RIPE, RIPE, rifampin, INH, pyrazinamide, ethambutol for 2 months, followed by RI alone for 4 more months. 6 months total. And of course, add pyridoxine. Know the diagnostic treatment. Know the diagnostic algorithm and latent and active treatments for TB. Always give vitamin B6 with INH exceedingly high yield. Okay. So this lady has latent TB. So PBD skin test is first done. If history of BCG vaccine, so basically if they had tuberculosis before, then you don't do the PBD test. You do the interferon gamma release assay test. If the PBD is negative, repeat after 1 week. Again, you can um, get false positive with the repeats because you had a previous injection of PBD. If the IgRA is negative, no further test needed. If the PBD IG or IgARA is positive, do a chest X-ray. Do not repeat positive PBD test. If the chest X-ray is negative, you treat for latent TB, give TB prophylaxis. On the US only treatment for latent TB and administer TB prophylaxis means the same thing. If the chest X-ray is positive, treat for active TB. Okay, so I got it. So if they're saying that somebody if someone's an immigrant, they come in, you give a PBD shot, they have um, like that bump is over um, 5 or 10, 5 or 10, you have to do the IGRA. No, you don't. You don't. If it's over 5 or 10, you have to then do the chest X-ray. So if it's over 5 or 10, um, that's abnormal, and you have to repeat the test, even if it's negative. Let's say they both come up as like 10 each time. Then you have to do a chest X-ray. If the chest X-ray is negative, you give pyridoxine and INH for 9 months because that patient has latent TB. And if they have active TB, you give them, like the chest X-ray is positive, you give them a RIPE treatment. Okay, that's it. I'm gonna write this down. Agent responsible inhibits what? A 26-year-old man from the Philippines has a positive interferon gamma release assay and chest X-ray for TB. Treatment is initiated. He develops orange bodily secretions, including his sweat and tears. The agent responsible inhibits what? I think I just did this. Oh my gosh. I don't know. Is it DNA dependent RNA or is it RNA dependent DNA polymerase? It's something polymerase. Okay. Yes. Okay. Okay. So, rifampin is a DNA-dependent RNA polymerase inhibitor. It causes bodily secretions. This is a benign finding. Mechanism of action of TB drugs are exceedingly high yield on step one. Okay, that means memorize this. Um, the man being treated with rifampin, isoniazid, and pyrazinamide and ethambutol for active TB. Rifampin is a DNA-dependent RNA polymerase inhibitor. DNA-dependent RNA polymerase inhibitor. It is known to cause orange bodily secretions in a man. This man worry patients. This may worry patients. Guys, I promise I don't know how to read. I'm reading really fast, so my words just jumbling together. But it's okay. This may worry patients, but it's a benign finding. It's just a red man tears is just a side effect of rifampin. INH is a mycolic acid synthesis inhibitor. Pyrazinamide inhibits fatty acid synthase 1. Ethambutol inhibits arabinyl transferase. Okay, I'm gonna take a picture of this. But rifampin is without a doubt the most important one there. So I'm gonna write that down. Rifampin, rifampin is a DNA DNA dependent DNA dependent DNA dependent is a DNA dependent RNA polymerase. RNA polymerase 22. Okay, let's take a photo of this. Okay, next. Which of the following is most likely responsible for this condition? A man who has been to the hospital many times over the years for Wolff Parkinson White syndrome is treated with an agent that successfully produces a complete anterograde block in the accessory pathway. This is not the first time he has received this therapy. Several weeks later, he develops joint pain in his hands, sharp pain when breathing, purpura on his trunk, redness of his shins. Which of the following agents is most likely responsible? Okay, so he has Wolff Parkinson White syndrome. Um, he produces a complete, he gets a treatment that blocks the accessory pathway. Um, Now he's having side effect to the treatment. It's causing sharp pain when breathing, purpura on the back, redness of your shins. What is it? Dofetilide, Enurin, mexilotine. I think procainamide causes SLE, like I don't even know what the other stuff does. Amiodarone causes some kind of fibrosis. I don't know. Oh, it is. Okay. So procainamide is type what? 1A antiarrhythmic sodium channel blocker may be used to produce an effective block of accessory pathway. Procainamide is classically associated with drug-induced lupus erythematosus. Okay, dial and SLE. are distinct conditions. Yeah, they are. So, arthralgia is often the first symptom and presents up to 90% of patients in both SLE and DILE. CNS and renal import in oh my goodness, CNS and renal involvement are very rare in DILE. Photosensitivity, purpura, and erythema nodosum are more frequent in DILE. Molar rash, alopecia, discoid lesions, and mucosal ulcers are less common in DILE than SLE. So this patient had pleurisy. It's a sharp pain when breathing, is seen in both dial and SLE. However, it's more seen with procainamide. Drugs classically associated with dial are minocycline, hydralazine, isoniazid, procainamide, penicillamine. Minocycline, hydralazine, isoniazid, procainamide, and penicillamine. Dial is associated with antihistamine bodies. Okay, so bottom line, antihistamine bodies are characteristic in drug-induced lupus. Renal involvement and malar rash are rare in dial compared to SLE. Purpura and erythema nodosum are seen in dial. Both dial and SLE present with arthralgia as the most common symptom. Pleurisy is seen in both, however, is most commonly associated with procainamide. This type of question is exceeding high yield for USMLE. Okay, so Wolff-Parkinson syndrome is caused by the presence of an accessory conduction pathway in the heart and frequently results in paroxysmal supraventricular tachycardia. WPW is classically associated with a delta wave on ECG, which is collectively referred to as a slurred upstroke of the PR segment. Procainamide is a type 1A antiarrhythmic sodium channel blocker, may be used to produce an effective block in the accessory pathway. Okay, I'll write that down. Okay, so which of the following is the most likely mechanism? Which of the following is the most likely mechanism of aging she was treated with? 23-year-old lady, permagad woman at 28 weeks gestation presents to ED with headache and general feeling of severe discomfort. Her BP is found to be elevated, and she is treated with an agent that is known to improve mortality and heart failure when combined with nitrates. Her BP proceeds to decrease appropriately, which of the following is the most likely agent she was treated with. Okay, so whatever she was treated with improves mortality in heart failure patient when combined with nitrates. Nitrates are what? Nitrates are nitroglycerin. Um, um, beta blockers. I'm gonna say that it's the ACE angiotensin converting enzyme. ACEs and ARBs. Where's the beta blockers? I don't know if you combine beta blockers and nitrates. Let's see. Hey, none of those. Okay. Hydralazine we use as a first-line treatment for severe hypertension in pregnancy. It decreases afterload on the heart. Combination of hydralazine and nitrates is the management of heart failure. Is well known to decrease mortality. This is not that well known. Okay, so the reduction in mortality in heart failure is especially pronounced among black people, as cited by major New England Journal of Medicine. Hydralazine's mechanism is described as direct relaxation of arteriolar smooth muscle, probably by alteration in intracellular calcium signaling. The mechanism is not fully known, but theorized to be due to interference of calcium movement into the vascular smooth muscle, which is responsible for vasoconstriction. Hydralazine, by altering cellular calcium metabolism, interferes with the calcium movement within the vascular smooth muscle that are responsible for initiating and maintaining the contractile state. Hydralazine cGMP independent vasodilator, meaning independent of the actions of phosphodiesterase 5. Hydralazine can be mentioned in the has mentioned in the past in various step exams as a phosphodiesterase inhibitor. However, literature doesn't support this whatsoever. Sildenafil is Viagra. It's a phosphodiesterase 5 inhibitor. It prevents the breakdown of cGMP. Xylostazol is an antiplatelet agent, as well as vasodilator used in the treatment of intermittent claudication. It is a specific and strong PDE3 inhibitor. It prevents the breakdown of CAMP. Dipyridamole, both an antiplatelet agent as well as a vasodilator, used sometimes in cardiac stress testing, is both a PDE and PDE5 inhibitor, preventing breakdown of CAMP and cGMP. Okay, so you had to know that hydralazine uh, paired with nitrates decreases mortality in heart failure patients. And hydralazine acts by interfering with the signaling and or movement of calcium in vascular smooth muscle. The literature doesn't support the conclusion that hydralazine is a phosphodiesterase. Yeah, I never heard of hydralazine being a phosphodiesterase inhibitor either. So basically, hydralazine causes arteriolar vasodilation. Next, we have this. A 62-year-old man. A 62-year-old man presents with a 3-month history of dry cough and burning sensation in his throat that is particularly worse when lying down after meals. He has a 20-factor history of smoking and drinks 4 beers a day. He has type 2 DM managed with insulin. Pinpointed discrimination is impaired up to what? Pinpoint discrimination is impaired up to his knees if farm treatment is attempted for this patient's esophageal symptoms, which the following is appropriate. Okay, so he has dry cough, burning sensation in his throat, is worse after meals. Okay. Uh, omeprazole, I think he's good. Oh no. No. Dang it, it's not GERD. It's diabetic gastroparesis. What the heck? Okay. So this guy, this is a man with new onset GERD symptoms and also has diabetes mellitus, and pinpoint discrimination is impaired up to his knees. He has gastroparesis from long-standing diabetes, as you see with impaired pinpoint prick. That's them telling you that he can't feel sensation in his knees. So that's a side effect. Not a side effect, it's a direct effect of long-standing diabetes. It's a gotcha question. Answer is metoclopramide, which is a D2 antagonist used for diabetic gastroparesis. Yosemite favorite, as indicated on this page. See this? Use my favorite question. And I got it wrong. Okay. So, metoclopramide is a prokinetic D2 agonist used in the first-line form therapy for diabetic gastroparesis. Yosemite shall present as a guy with GERD who has advanced diabetes. Don't fall for PBI trap. However, if the vignette is a genuine version of GERD, choose the PBI over the H2 blocker. PPI is omeprazole, H2 is cimetidine. So choose, if somebody has GERD, choose omeprazole. Okay. Now, which of the following is the most appropriate initial pharm therapy for patient? For a 54-year-old man with a history of chronic renal disease secondary to granulomatosis with polyangiitis presents with a painful ulcerated tropus located on the first metatarsobophalangeal joint. He has 36-year packing history of smoking, which of the following is the most appropriate initial pharm therapy? He has renal failure, so we cannot give a drug that is renally excreted. Okay. So what do you give for initial therapy? I thought it was colchicine because allopurinol is for long-standing. Is colchicine really renally excreted? I mean, I'm gonna go with colchicine. I don't know. Corticosteroids. Hey, yo. Here's only trick question. Indomethacin, colchicine, corticosteroids are all acceptable and comparably effective first-line treatments for acute gout. Okay. In U.S., indomethacin NSAID is standard for acute gout. Obviously, most questions on acute gout will have indomethacin as the answer. However, this patient has renal insufficiency, making NSAIDs and colchicine inferior selections compared to steroids. Oh, I see. So, indomethacin, corticosteroids, and colchicine are all acceptable and comparably effective first-line treatments for acute gout. On step 1, indomethacin is the answer. However, a patient has renal insufficiency, choose corticosteroids. Colchicine will be the answer if indomethacin and corticosteroids are not listed. Okay. So, for acute gout, you give indomethacin, corticosteroids, colchicine, 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 colchicine. Okay. But if the patient has acute gout with renal insufficiency, renal failure, answer is corticosteroids. Okay, so acute gout, you give indomethacin, corticosteroids, and colchicine. I mean, so you give for acute gout, you give indomethacin, corticosteroids, or colchicine. However, in acute gout with renal failure, you give corticosteroids. So, corticosteroids are mainly broken down by the liver. Colchicine is broken down by the liver and excreted in bile and urine, but it can accumulate in renal failure. Colchicine can accumulate in renal failure, and endomethacin can also accumulate because endomethacin is metabolized in the liver but excreted mainly by the kidneys, making it unsafe in renal failure. So that's why corticosteroids are safe in acute gout with somebody who has CKD, and not safe, and endomethacin and colchicine is not safe in somebody who has acute gout that has renal failure. Okay, next. "12-year-old girl with sickle cell is administered an agent that increases her fraction of fetal hemoglobin and decreases the frequency of vaso-occlusive crises. Agent best described as what?" So what increases HbF and decreases the vaso-occlusive crises? Agent best described as what? Prevents addition of hydroxyl group to the deoxy ring of deoxynucleotide diphosphate. Um, I'm gonna go with A. I'm not sure. And it was D. Hydroxyurea is a ribonucleotide reductase inhibitor used in treatment of sickle cell disease. Increases HbF and decreases vaso